This talk is on PEM, which is Pediatric Emergency Medicine. Just a little bit of background before I launch into it. When we are looking at emergency medicine, we need to consider the Constitution because it's really important that we provide quality care for all humans in South Africa. And just quoting some of our Constitution, everyone has the right to have access to healthcare services. This means that it's everybody, not only South African citizens or South African nationals, everybody in the country that presents to an emergency department has the right to access. If you look at the Constitution, it says children have the right to access to basic medical care and social services. So special mention has been made about children and their rights. And furthermore, in the Constitution, it says no one may be refused emergency medical treatment. When you look at the Children's Act, always we need to make decisions that are in the best interests of the child. It's much more difficult and probably unethical and against the Children's Act to triage children away from a hospital. So why am I going on about access to hospital, accessing medical care? We have so few facilities as it is around Africa, and even less that are dedicated services providing dedicated care for children. In Africa, this is still one of our major challenges. And this is a map, although it's a little bit older. The research was done in 2015, showing the density of medical services provided in different parts of Africa. So the yellow areas, patients have much less access and have to travel much further, longer distances to receive medical care. The orange areas have moderate access, and the green areas are the areas that have the best and closest facilities to them. So you can see that the yellow and orange areas by far outweigh the green areas. So we have the exact same problem of limited access to medical care here at home in South Africa. We're a country of extremes. We have extreme wealth and extreme poverty. The honest truth is that the greater proportion of our population has to access government state facilities as opposed to a very small part of our population which is able to access private facilities. So at home here in South Africa, we don't only have problems with access to medical care, we also have problems with regards to accessing quality medical care. This is particularly important when we need to access quality medical care for children. So emergency medicine is a speciality that has grown and developed out of need. We need to have experienced clinicians, experienced providers at the front of the hospital or in the emergency medical services, or as the first point of contact, that are able to deal with a broad spectrum of clinical cases and conditions in order to be able to stabilize and resuscitate individuals. So this map from 2016 shows the extent of emergency medicine training across Africa at the time. The blue areas show where there are postgraduate training programs in emergency medicine. And the green areas are where there were specialist emergency medicine training programs or registrar training programs. So programs that are designed to produce specialist emergency physicians. So while there are countries around Africa focusing on emergency medical care, there are large portions of the map that are grey where there is no emergency medicine training happening. So what happened in South Africa? In 2004, emergency medicine was government gazetted as a base speciality. This means it's a speciality in medicine, much like pediatrics, surgery, internal medicine, and in anesthesiology. The University of Cape Town were ahead of the pack, and they started training their first emergency medicine postgraduate students. So these were doctors who were specializing in emergency medicine. They began their training in 2002. The University of the Witwatersrand followed shortly thereafter, and the other universities as well also started training their graduates in emergency medicine. So, what exactly is Peds EM or PEM? So this is Pediatric Emergency Medicine, which is a field of clinical care focusing on emergency management of children. This is ill and injured children, as well as critically ill and critically injured children. So I'm a specialist emergency physician with a particular interest in pediatrics. I belong to PECSA, which is Paediatric Emergency Care South Africa, which is a special interest group of EMSA, which is the Emergency Medicine Society of South Africa. Across the continent, you'll find various organizations and practitioners who are keen on strengthening emergency care. AFEM, African Federation of Emergency Medicine, has got some really great resources on emergency medicine and emergency care, as well as resources on pediatric emergency care. IFEM, which is the International Federation for Emergency Medicine, also has a special interest group in pediatric emergency medicine. These are the organizations which drive pediatric emergency guidelines and research, as well as developing and growing the field of pediatric emergency medicine in their own countries. So what about formal pediatric emergency medicine training in Africa and formal education? While emergency medicine has grown as a speciality, pediatric emergency medicine is following suit. Around the world, there are a number of formal pediatric emergency medicine programs in Americas, South America, Europe, Australia, New Zealand, and in the UK. In Africa, on our continent, South Africa and Kenya are leading the formal pediatric emergency medicine training. Depending on where you live around the world will dictate whether you access pediatric emergency medicine as a sub-speciality or a super speciality, meaning you need to be a specialist in pediatrics or emergency medicine first before you can undertake pediatric emergency medicine training. Some parts of the world, the pediatric emergency medicine has grown so much that it is a base speciality, much like emergency medicine is a base speciality. But not all countries offer PEM as a base speciality yet. So what about back home? In South Africa in 2020, Dr. Zweli Mkhize, the Minister of Health at the time, government gazetted a new speciality. This was the new speciality of pediatric emergency medicine, which is a subspecialty or a super speciality available to pediatrics and emergency medicine. This means that you have to be a specialist pediatrician or a specialist emergency physician before subspecializing in the field of pediatric emergency medicine. Prior to this government gazetting of pediatric emergency medicine, there wasn't much formal pediatric emergency medicine training. There were some courses, pediatric emergency care, burns care courses. The University of Cape Town offered a postgraduate diploma in clinical pediatric emergency care, mostly aimed at medical officers working in or running emergency departments across the continent. But things have changed. So where do I work? This is familiar to most of you who work with me. This is Rahima Musa Mother and Child Hospital. We are one of the only specialist pediatric and mother and child facilities, and the only state one in South Africa. I hate the term casualty. Those of you who work with me know casualty is referring to a sick person. It's a person, not a place. And we consider it a swear word in emergency medicine. We really don't like where we work to be called casualty. We are not casual doctors. We're very proud of our speciality and what we do and the level of expertise that we bring to our field. All right, so if you are looking at the term casualty from a military definition, that is a combatant or non-combatant person who is now unavailable for duty. And it can be because they were injured, illness, they were captured, or they died. If we look at the term casualty in the civilian literature, that is a person who is wounded, injured, or incapacitated. It is also used to describe multiple injuries and or deaths due to major disasters or incidents. So let's say there's a bus accident, there can be a number of casualties. Casualties is not a place, and if you work with me, you'll get charged 200 Rand now for using that word, and you'll pop it into the swear jar and it'll go to our end of year function. Okay, we are very proud to work in an emergency department. So inland, we call it emergency departments. At the coast, especially at UCT and Stellenbosch, they'll call it an emergency center. Okay, the basics. How do we triage patients? How do we know and identify who is sick? So have a look at the Paediatric South African triage score chart. This was developed in South Africa and has been accepted worldwide as an amazing scoring system. So we also have the adults SAT chart, and you guys will recognize this because this is in every single triage bay in all of the emergency departments across the country. So the main focus of pediatric emergency medicine is to treat life-threatening emergencies. This means that our clinicians need to be excellent with resuscitation and to have really good skills. While it's the exciting part of our job, only about 10 to 20% of our work actually is resuscitation and true life-threatening emergencies. The rest of the time, we have varying degrees of illness or patients with varying degrees of illness or injury in our departments. We are also in the field of stabilization. So as unstable patient comes into the ED, it is our job to stabilize that patient. So that might mean putting in lines, central lines, intubating the patient, reducing a fracture, putting in an intercostal drain. We love procedures in emergency medicine, and keeping this patient alive. And as I mentioned, we love procedures of all sorts. So tubing, doing CPR, putting in intraosseous, doing an umbilical catheter, maybe putting in a central line for your child with burns that's got a severe injury. The pediatric chain of survival includes activating the emergency response system, high quality CPR, advanced resuscitation, that's us. But if you're not doing high quality CPR, advanced resuscitation is pointless. Post-cardiac arrest care is super important in emergency medicine because when you get a pulse back, what do we do with those patients? But we don't just want to get pulse back. That's not the be-all and end-all of a resuscitation. We want neurologically intact children to go home to their parents. Patients that can continue playing football at school, become a dancer, go on to study to become an engineer or a teacher or a technician. So we really want the whole loop in it. The one thing that's very important in pediatrics is early recognition and prevention. Most of the injuries that we see in an emergency department, especially peds emergency medicine, are entirely preventable. Okay, when patients come into an emergency department, kiddos included, they are often in pain. They've come in because they've got a broken leg, they bumped their head, they fell off the jungle gym or fell off the counter at home, and they come in crying and screaming, and they really need something for pain. Your job working in an emergency department is to provide pain relief. Yes, you might not be able to perform the appendectomy for the child with a ruptured appendicitis. We have to refer that child to the ped surgeon to operate. But what we can do is we can stabilize, make sure they don't go into septic shock, treat them with antibiotics, but above all, make sure that you provide excellent pain relief. This picture is showing an atomizer, and I really hope that all of you guys are familiar with using an atomizer in the emergency department. If you're lucky enough to have a formal atomizer, great, go ahead and use it. Otherwise, you can make one, you can jimmy one by popping a tiny little hole in the end of a cannula and still spraying. It will still cause the particles to be much smaller. We're not squirting a volume in the nose, we're trying to spray tiny particles into the nose that can be absorbed in the mucosa. Okay, so what patients define pediatric emergency medicine? Why is it different from pediatrics? And pediatric emergency medicine, we do see a lot of pediatrics in peds EM, but there's more to pediatric emergency medicine than only pediatrics, medical pediatrics. We have a horde of undifferentiated patients that arrive. We have a patient, a kiddo, that will arrive unconscious. And as we do a clinical exam, and maybe we're lucky enough to get a good history, we can flesh out that, oh, actually, this patient is having seizures. That kiddo bumped their head yesterday, so it could be a traumatic brain injury, or it could be a meningitis, or it could be an electrolyte abnormality. So they don't come in with a label saying, oh, I belong to internal medicine, pediatrics, or, oh, I belong to neurosurgery, so peds neurosurgery. We are the ones that see them when they don't have a diagnosis. We have to do a good clinical exam, some targeted investigations, bedside investigations, and come up with great differential diagnoses and a plan of action in the ED. So this is a cute slide that I really like to use to show what is the difference between undifferentiated cells that then become specialized cells. So we get patients when they are undifferentiated. And by the end of our consult, we usually sort of know that maybe it's going to be an orthos case, maybe it's going to be an ENT, the child's got a foreign body in the nose, maybe it's going to be a neurosurgical case. Regardless of what the diagnosis is, we are still the ones that are managing the foreign body in the nose and getting it out, splinting and reducing that fracture, and then referring them on to orthopedics, maybe for later surgery or just for follow-up, or intubating the patient and managing their intracranial hypertension and cerebral edema, and then referring them on to neurosurgeons for definitive care. The difference is though we don't necessarily have a diagnosis quickly. So family medicine, they have to come up with a diagnosis in 2 to 5 minutes. We will probably have up until about 4 hours to come up with a good diagnosis, or at least ruled out a whole bunch of things. But sometimes our patients are still undifferentiated based on we need further investigations, and they might need to go to another facility, for example, for a CT scan, or we wait for blood test results, and we're waiting for things that help us determine whether or not, or the disposition planning for the patient. The main job of emergency medicine, however, is to rule out life-threatening diagnoses. And this is the same for pediatric emergency medicine. Our job is to rule out life-threatening diagnoses. You might not necessarily have a definite diagnosis by the end of it, and don't be worried by that. Emergency medicine, pediatric emergency medicine is fraught with uncertainty. As long as you know that your patient is stable and is okay, you're managing their symptoms, and we've got a really good disposition backup plan with health education to return should something bad continue. This is good clinical practice. All right, so please don't feel that your job is to make the diagnosis. It's to come up with excellent differentials. Okay, we are also medical detectives. Pediatric emergency medicine is all about being a pediatric medical detective. We don't necessarily know the final diagnosis. If you're lucky, if you're friends with the person that you're referring to, sometimes they give you feedback and then you know what's going on with the kiddo. A lot of the time we don't really know though. We're trying to make snap decisions. Peds emergency medicine is one of the specialities that you have to make the biggest number of decisions in one day. All right, so it's important for us to choose our investigations, so do appropriate targeted investigations. Please don't do a FBC, UNE, CRP, CMP plus albumin, LFT, and serum rhubarb on every single peds patient you see in the ED. It's most of the time not relevant. We have to make a decision at the bedside. This child is well enough to go home. Maybe I need to investigate and I can get them to follow up at POPD or at an appropriate place. Do we actually have to do those investigations in our department? Because we do need to be cost effective. We see a huge number of patients. So my ED, Rahima, we see about 29,500 patients a year. And we need to be very mindful about what we investigate and what we don't. Don't fall into the trap of over-investigating. If a patient is well and stable, they don't necessarily need any blood tests at all. Okay, we can potentially just do an ECG, a urine dipsticks. If they need a gas, do one. If they don't do a blood gas. I've mentioned this earlier, that it's important to come up with a differential diagnosis. Don't freak out if you don't know what's going on. All right, our job is, can we stabilize them? Can we keep them alive? Can we make safe decisions for them? And safe decisions include safe disposition planning, so safe referrals, really important to educate the patient. So the teenagers, you need to educate them and the parents when to come back, what is worrying. Give them, for example, a head injury chart on when to come back with a phone number so they can call. Give them advice on how to rehydrate the patient at home, how to make sorrel if their sorrel sachets have finished, when to come back, what are the signs of severe dehydration. Safe disposition planning also might mean really safe referrals. So if it's not safe to send a child home, especially if you're worried about non-accidental injuries in the home, safe disposition planning means admitting the patient as a social case, because we are now trying to make the hospital the safe place of safety. So, and this is also another difference in peds EM versus adult EM. We will do more social admissions because we're worried about the safety of the child. Remember that when it comes to peds patients, the health and well-being of the child is tantamount. So that guides every single decision that we make for our patients. All right, so yeah, everything might be a whole heap of mess in emergency medicine, and particularly in peds emergency medicine, because you'll have a 14-year-old child who is pregnant and is having a miscarriage, and now you've got all of the ethics of what to counsel about, and can we tell the parents, and does she want to know, and can the patient sign consent for her own D&C, versus a teeny weeny neonate who is just vomiting, and now we have to kind of come up with a great diagnosis and plan and what's going on. So in peds EM, it can really be a whole heap of mess, but we like to make order out of the chaos. And one of the things that we can use to help make order out of the chaos is using clinical decision tools or rules. And you might have come across these as clinical decision aids. So they're really nice, evidence-based, step-by-step decision tools that will help you to make a diagnosis, or at least safe disposition and safe management planning. So this is a picture of a patient who has bumped their head. You can see they're crying, they're miserable, they've got a bruise on the frontal area. They're a small kiddo. How do we know if they need to go for a CT scan? Well, we have this fantastic clinical decision tool called PECON. So PECON is split into two different categories. Are you a small child or are you older than 2? And go through it step by step. It helps us guide, do we observe the child or do we have to go and book a CT? And at the bottom, it's really cute. They actually have a picture showing what are the severe mechanisms. So was the patient in a car accident? Were they ejected from a vehicle? Were they a PVA? Was there a rollover in the accident? Was it a kid that was riding a bicycle and was then bumped by a car they weren't wearing a helmet? Were they on a scooter or a motorbike? Did they fall from height? So if they are an older patient, did they fall from a height of more than 2 meters? Are they a tiny person, so a tiny baby? Did they fall from a height of more than 0.9 meters? So that is like a high tabletop in the kitchen, for example. So these are really helpful for us to decide what are we going to do with the patient. The use of PECON, we use it pretty much all day, every day in our emergency department, is actually looking at clinically important traumatic brain injuries. So they found that it's a really nice tool, 100% sensitive with a negative predictive value of 100% in the younger age group. In the older age group, also really good sensitivity of 96 and a negative predictive value of 99.9%. So these tools are helpful for us to use. And you'll see they guide what do we need to do. Who do we have to scan? Who can we observe safely in the ED for 4 hours and let them go home? Or potentially even the mum could observe at home as well, depending on the resources available to her or to the dad. Okay, another example would be a kiddo comes in with tummy cramps and abdominal pain. What do we do? Is it a gastro? Is it mesenteric adenitis? Well, there's some awesome tools that we can use for pediatric appendicitis. So if you look at the Alvarado versus the appendicitis inflammatory response score, we like using pediatric appendicitis score. Where can you find all of these tools? Well, we include them in our protocols in the ED, but you can also find them on Medscape, Dr. Google, and if you've got MedCalc or any medical calculator available. They're fabulous. They really are helpful. So if you look at the PEDS appendicitis score, it'll include clinical signs, clinical symptoms, and some lab investigations that are helpful. Then what do you do with it? Well, you plug it into which of the patients do I need to examine further and investigate further? Do I need to add a bedside ultrasound? Must I add a formal ultrasound? Do I have to CT the patient? Obviously, this particular tool uses an FBC. It uses a white cell count with a leukocytosis and a polymorphonucleoside of more than 75%. So we do have to have a lab test for it. Okay, those of you who are ultrasound fanatics, pediatric emergency medicine is just for you. All right, we love ultrasound at the bedside. This is one of my first ultrasounds that I did for a patient. I was working at the coast and I had a young patient with typical appendicitis, no radiology, no ultrasonographers after hours. The surgeons also always wanted blood test results, and because it was a district hospital, it took forever for the tests to be available. I decided, great, I've learned how to do an ultrasound. I looked at YouTube quite a bit. I'm going to pop a program, and it sure as nuts, exactly where the patient was tender, McBurney's point, I saw signs of obvious appendicitis. So a swollen, dilated appendix, a little bit of edema around it. If you see other features of appendicitis, that's great. It helps to rule in appendicitis. Please remember, a negative ultrasound does not exclude appendicitis. Even if it's a formal ultrasound, if they don't see the appendix, it's an indeterminate scan. Okay, so I always believe this, that there's absolutely nothing that an EM physician can do without an ultrasound, and it's the same for pediatric emergency medicine. We love our sonar, we love our procedures, we see quite a lot of trauma, and that's probably one of the things that is beneficial to emergency medicine subspecializing in pediatric emergency medicine, because we have so much surgical trauma training during our specialities and our rotations, even in the mixed EDs. And this is one of the things that is beneficial to us in a PEDS EM, that we've got these skills. Okay, we see a lot of trauma, patients with fractures, dog bites, open wounds, maybe you have zipper injuries, foreign bodies that need to be removed from every orifice that you can possibly imagine, incision and drainages, reductions, yeah, I'm trying to think of other procedures that we technically do. Oh, scrub down of burns. We see lots of patients with burns. So we have lots of patients that present with injuries, kids that need suturing. So don't believe that we are always having to refer to other people for definitive care. Very often, a lot of the time, we are the definitive care. Patient comes in, they've got a mild green stick fracture. All we do is we give them analgesia, backslab them, and to be honest, they don't even need a full circular cast. They can follow up with orthos in a couple of weeks' time. We have been the definitive care. Patient has a zipper injury, you might be scared, you might call the urology doctor, but that's painful there and then. You need to do the penile block yourself and reduce that foreskin injury. So we often are the definitive care for patients. So that's why we're a speciality. Yes, we do a lot of referrals, way more than any other specialty, but we also really are generalists. We are often the definitive care for that patient. Because we have so many procedures and we're administering analgesia, make sure that you are doing safe procedural sedation and analgesia. So use a checklist. I love this one. This is the one that's in our protocols at Rahima. Be prepared. So this is one of the things that is really important in an emergency department. Be prepared for anything to walk through the door. Emergency medicine, pediatric emergency medicine is any person, anywhere, anytime. Anything can walk through the door. Please, one other thing that's important is you have to have a high suspicion for non-accidental injuries, child abuse. It's almost like a hidden disease, so you have to have a really high index of suspicion. It's a chat that we'll have a little bit later in the year, specifically dedicated to sexual assault in children and non-accidental injuries and patterns of abuse. But for now, I just wanted to be on your radar. It's really important to have a good relationship with your social services and your local police. Use the pauper tape, your flipper chart, use your PEDistat app. I love it. It's great. I don't expect you at 3 in the morning when you've seen 40 patients combined on the shift to remember the correct doses. So use your flipper chart, use your pauper tape. We've got these in our department. I love Paedistat. Paedistat is my friend. But we've also got the pauper box system. So we've prepared it, and we've even laminated the cards onto the boxes so that we've got lots of safety netting in the department. What can you do to get better at pediatric emergency medicine and all of your pediatric emergency medicine skills? Well, practice, practice, practice. Nothing else is going to get you better rather than experience and time. So practicing, yes, with real live patients, that's how it is in South Africa. But we can also do sims. And yes, this is a picture from back in the day. We've got one of our current senior emergency medicine MOs in the ED and one of our junior obstetric registrars in this picture. They've both given me permission to use it. This is how our resus bay used to look, and here we are practicing airway skills. So doing sims, doing practice is really important, and this is also an important part of Peds EM. We love doing sims and we love doing hands-on training. One thing that makes us probably stand apart from some of the other specialties is that we have an excellent understanding and relationship with emergency medical services. We do rotations in EMS, and that is beneficial, especially when transporting sick children, cardiac kids, preterm babies. Wow, those are some of the scariest patients to look after, because you think that it's scary looking after a sick child in an ED. In the chaos of an ED, well, in the chaos of the pre-hospital environment, when you're moving in a bumpy ambulance or the back of a helicopter or aircraft, is even more challenging. So it's particularly important to have specialized teams working in pediatrics in the emergency medicine services too. And depending on where you are in the world or in our country, you very well might get some peds specialists accompanying the patients for their medical conditions. So Peds Emergency Medicine is all about collaboration. We have to have excellent relationships with the teams that we refer to and the teams that we get advice from. So we have a great relationship with POPD, and our POPD MOs actually do their overtime in the ED, which is fantastic. They share their knowledge and skills with us. Hopefully we also share some of the things that we know with them. Get to know your PEDS registrars, MOs, and consultants, because they are your friends. But more than that, we don't just refer to pediatric or internal medicine pediatrics. We refer to ped surgery, neurosurgery, other hospitals, trauma surgeons, a whole bunch of other facilities, because very often, even at specialized centers, so capitals in the provinces, you might be working at a hospital where you have a set of services, but you might not have the super specialty where this patient can be looked after by maxillofacial surgery at your facility. So you really have to get good at your referral pathways and knowing what needs to be referred and what doesn't. If you don't know, please ask. Okay, one of the things that you have to get comfortable with in pediatric emergency medicine is a level of uncertainty. We really do a fair amount of safety netting, and we often don't actually know what the final outcome or diagnosis is going to be. You've got to be comfortable with making snap decisions and going with it, making sure that you have given safe return instructions to the family. This is just one of the things about our specialty. More than that, though, and I mentioned it a little bit earlier, when it comes to Peds EM, there's something really rewarding about looking after children. And this is the thing that's probably underplayed the most in emergency medicine, is we have to be caring and compassionate. And Peds EM is a field that allows you to be caring and compassionate, and you can be softer, and you don't have to be necessarily quite as tough. And it's important because we're not only looking after children, but we're looking after their families. And it's important to be sensitive. And we're breaking bad news so often in an emergency department. We have endless out-of-hospital cardiac arrests and DOAs. Mums are always waking up and finding that their child has demised overnight, rushing the patient to hospital. So you really have to be good at communicating, containing emotions, sharing the sadness of a loss, and having sensitivity when we lose patients in the ED. I really believe this. My comserves that came to me from internship at Barra say that this is one of the favorite Barra quotes. Teamwork makes the dream work. And it really is true about emergency medicine. We kind of share a brain, so it means on call, discussing your cases with the other people, bouncing off ideas, maybe reviewing an x-ray with a colleague because we don't get reports after hours, and reviewing your management plans with other people. We do a lot of collaboration in the ED, which is great. It means usually that best practice is followed. Don't try and come up with a plan by yourself, especially if you're not sure. Ask for help. Discuss the patient with your consultant, a senior MO, the reg, a colleague in another department, for example, the pediatrics reg. Really rely on the resources around you. Just some nice resources for pediatric emergency medicine. I love Don't Forget the Bubbles, one of my favorite blogs and websites, but some other nice blogs for Peds EM. And also, I'm going to punt it because I'm very proud of the work that our guys have done, which is the YouTube channel for Rahima Musa Mother and Child Emergency Department. We have got so many resources on here put together by our own team for our emergency medicine team on pediatric emergency medicine. Go and check it out. There's some really cool videos. Lots of time and energy have been put into it. So this is the quote that I'm leaving you with. Unless someone like you cares a whole awful lot, nothing is going to get better. It's not. I like Dr. Seuss, and the quote's from him. And I really do believe that you have to be in it to fix it. You have to be in it to make it better. And that's one of the most positive things that I think about pediatric emergency medicine. We have the potential to make a huge difference.